This conference will now be recorded.
Hi, everyone. This is Len Sierra with AnCan's High Risk Recurrent and Advanced Prostate Cancer video chat for Monday, September 16, 2024. I'll be moderating today with help from my fellow moderators. And first thing we do is thank and acknowledge our sponsors making this presentation possible. And they are Bayer, J&J, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. All right, so let's see. Where is James? Do you have your video on, James? I don't see you right now.
Yeah, here I am.
Oh, there you are. Okay.
Yeah, good
very
evening.
good. Good evening and welcome to the AnCan Advanced Group. I'm going to ask you a few questions, and just to try and keep you in proper chronological order, don't try and jump ahead of my questions, please.
Got you.
So, all right. So, James, first, how old are you?
I am 55.
Okay. And where do you live, James?
I live in Detroit, Michigan.
Okay. First of all, how did you hear about AnCan?
I think I left a message on the newly diagnosed Facebook group.
Okay.
And then someone who might be on this call suggested this group.
All right. What was your age when you were diagnosed?
54.
So last year. And what was your Gleason score and your PSA at the time of diagnosis?
My highest Gleason score was 8.
Okay.
And my PSA was 65.
Okay. So what did they do next? Did they do an MRI scan or a CT scan and then an ultrasound fusion biopsy, which is what they should have done?
Yes, I had a lot of tests and then a PMSA scan, which
good.
determined that the cancer was not metastatic.
Good.
And so then I started my treatment. Like almost immediately, I started the androgen deprivation therapy.
All right. Did they do a biopsy?
Yes. At first, I had the biopsy, and that's what then initiated a series of doctors, and I went through radiation therapy.
Radiation?
Radiation, yes. I chose radiation.
What type of radiation? Do you know?
The SBRT or EBRT.
Okay. How many sessions?
28.
28 sessions. Okay.
Yeah.
Was it EBRT with what they call brachytherapy boost?
No.
No brachytherapy. Okay.
No brachytherapy.
Just the radiation and just radiation.
The EBR ADT.
ADT. Which one? Which drug?
Lupron, and then I think Eligard.
Okay.
Yeah.
No androgen receptor blocker?
No.
Okay. And the radiation?
That was offered to me, but I declined.
Okay. The radiation was only to the prostate, not the pelvic region?
Correct. I think for safe measures, they targeted the lymph nodes.
Oh, they did. Okay.
Yes, I think.
All right.
Went through radiation therapy, and then continued with the ADT for another 8 months.
Is that what they told you? Just 8 months?
No, I decided to take a break.
Okay.
And
at
then
the time you took the break, what was your PSA?
0.
All right.
0.
Had it just turned 0, or is it 0 for a while?
It's been 0 now for the last 8 months or 5 months. I mean, it went down pretty rapidly within the first few months and has remained that so. And my last PSA test was about a month ago.
Okay.
Yeah. I should add that then I was told I had the BRCA2 gene mutation.
Uh-huh.
Yes.
And was that germline or somatic, meaning inherited, or it was only in your tumor cells?
It's inherited.
Okay.
My sister had it or has it. My brother has and had a prostatectomy, and my uncle also had prostate cancer. So it's definitely in the family.
And did they talk to you about a drug called a PARP inhibitor?
Like, what's that stuff called? What's the name
Like
brand of that?
olaparib, Lynparza. It's a drug they use for people who have the BRCA mutation. Very
No.
effective, very targeted. Okay.
No, and I would love more information about that. I'm still sorting this out with the added complication of the gene mutation. So I would love your thoughts on that. I'm supposed to get something called like genetic counseling.
Yes.
But still trying to get that appointment made and how that will affect.
You,
yes.
Who's on your medical team right now? Like just a radiologist? Do you have an medical oncologist?
Yes.
Sorry?
Yes, I have an oncologist.
You do? Okay. And do you know if they specialize
a radiation oncologist or a medical oncologist?
A medical oncologist.
Okay.
Do you know if that person is a GU or genitourinary medical oncologist? Someone who specializes in cancers of the GU region, particularly prostate cancer?
I can't say that.
You want to give us the name?
Sure. My doctor, I have a whole team of doctors actually, because I'm very close to Ford Health Systems. It's a huge hospital complex. They have a cancer research center, a lot of doctors. My referring physician, his name is Dr. Feldman. And my oncologist, her name is Dr. Jasti, Jasti at Ford Health Systems.
Okay. Any of these familiar to you, Rick?
No.
Okay.
No. So the the ADT was pretty complicated, and being still a relatively young man and single, and that now with the BRCA2 mutation, I concluded that it was okay to take a break, see what would happen. And but now, I mean, they were telling me that, with the added, I think it's called Zytiga, is that correct?
Yeah.
Right. And that was like, the side effects of that was like, not good. So I said, I'll take my chances. But now, I mean, what I was trying to say is they were suggesting that I could be cured if I put myself through a lot of hell for years. And then it was like, there are no guarantees, of course. And with the BRCA2 mutation, it seems like I'm going to be stuck with this for some time to come. So, did I dodge a bullet? Will I have to deal with this again? I think it's quite likely given the gene mutation. So, my next PSA test will be in November. So, where that takes me, I mean, right now I think I'm doing pretty well, but I'm concerned about the mutation, and I think that it's just like, it's just going to be something I'm going to have to learn to live with.
May very
And
well be, but no one can predict the future.
right.
But we definitely recommend that you speak to your medical oncologist about a PARP inhibitor, PARP inhibitor.
Well,
ARP.
to speak to them, but I'd like to say a little bit about the PARP inhibitor, especially early in the process.
Go ahead.
First of all, James, cure was never on the table, and if they spoke to you about cure, they were misspoken, because we don't know how to cure 4+4 prostate cancer. We probably don't even know how to cure 3+4 prostate cancer. Never mind 4+3. The best that you can do is a durable remission. What was the stage? Where did they stage your prostate cancer? Were you a T1, T2, or a T3?
They described it as a 2.5. So it's not metastatic, didn't escape to their knowledge, right? They said there's a chance that it could be microscopic, and that, as you know, it's a very slow growing cancer, but they described it as a aggressive or high risk cancer.
Right.
Which
It's
I
high
never
risk,
really,
but is it, what was it, these terms are clearly defined. So they, at some point, should have indicated whether you were a T3, a T3A, a T3B, a T3C, or a T2A, or a T2B. That tells us if the cancer, if you were a T3, it would tell us that the cancer was found outside the capsule. If it
it
was, if
was not. It was not.
it was not. So the use of PARP inhibitors early on in the disease is pretty controversial, and I know a little bit about this right now because we've got a gent who is just entering a trial at Memorial Sloan Kettering, who's 50 years old, BRCA positive, germline, and was scheduled for surgery. But there's a trial there that has what's called 6 months neoadjuvant, meaning before the surgery, use of ADT plus PARP inhibitor. And he's decided to participate in that trial. I think he starts this week. He signed the papers last Thursday. Now, I have spoken to a bunch of docs on his behalf, very solid, very good docs. And there's some controversy as to whether you should use that PARP early or not. The problem with the PARP inhibitor is it's very toxic. We've got a gent right now who has just spent 2 weeks in the James Comprehensive Cancer Center at the Ohio State because he started on the PARP inhibitor and it really messed up his GI tract. And it's not the first time we've heard this. It's a really, really toxic drug. That said, it's effective. And it's not really clear if you're diagnosed BRCA with a BRCA germline, and your 4+4, whether you would use it early. We've had a lot of BRCA people, and I will add you to our BRCA list. Provide me with your email address. Provide us with your email address, and we have a BRCA Brothers list, which goes out to a whole bunch of guys. We've probably got 15 or 20 at this point who have a BRCA mutation. Some of them, like Jeff Marchi, who has his hand up, are more advanced. Some of them were 3+3 doing active surveillance, and when they shared their BRCA diagnosis, it was recommended that they do surgery, and they're doing fine. So it's just not clear. I think what is really important is that you work closely with a specialized medical oncologist who really understands BRCA. And we have access to a couple of those here. One in particular truly understands BRCA because she carries it herself, and she runs the BRCA Research Center at UCSF, and she gets it really well. We have other doctors who understand it, but they are GU docs. The lady who runs the BRCA Center does some stuff in prostate cancer, but she's not a genitourinary medical oncologist. She's a breast cancer medical oncologist by training. But I think that what you really need, it looks like this lady Justi Pallavi is just a medical oncologist who specializes in blood cancer, and especially with a BRCA mutation, we'd strongly recommend that you bring a GU medical oncologist onto your team.
Terrific. How would I send you my email address?
You can put it in the chat window. The chat window with the 2 stars, the 2 boxes at the top, and you can just send it to me directly, and we'll sign you up. And we also have an under 60s group, James,
Okay.
for men with stage 3 and stage 4.
I'm just going to put it there in the chat.
No, we got it. Thank you. Yes, other people might want to reach out to you too, but that's great.
Certainly. Yeah.
We have an under 60s group. We don't have any of our under 60s men in here tonight, but we've got a bunch of under 60s guys. That group meets just once a month. It's a really good group, and we sort of talk about some of the issues that you're faced with as a younger man. And I also would like to connect you to this fellow who is going through the trial. So he's deferred his surgery now because he's going to do the PARP inhibitor, and I think it'll be really helpful for you, and I think it'll be helpful for him. He's not much older, he's not much younger than you are, and he's going through some of these same issues, but he's made a decision to do surgery as opposed to radiation.
Certainly. I was told that choosing a treatment, whether it be prostatectomy or brachytherapy or simply radiation therapy, that it was important to do something, and that among all those choices, that the outcomes were more or less the same. So
well, they are. Yeah, I mean they are under normal circumstances, but
right.
I'm not sure they are with BRCA. I think that
Right.
there's definitely a leaning to surgery with BRCA for a number of reasons. I can't tell you I fully understand them, but when you talk to the really good urologists, for example, who are not pro-cutting, but like people like James Eastham at Memorial Sloan Kettering or Peter Carroll at UCSF, they lean towards surgery especially for a younger man. who has a germline BRCA mutation. The other thing is, and hopefully you didn't have a problem, but men with a germline BRCA mutation are more likely to side effects with radiation because there's a theory that the cells are more sensitive because every cell in your body has that BRCA mutation. That's probably been explained to you, I'm sure.
Actually, no.
Oh, it hasn't. So you see, and again, this is really why we really would guide you towards you have a fantastic person in your market, but she's about to leave. That's who we were talking about, who is Dr. Heath at Carmenos. But she's about to leave Carmenos and go to Mayo Rochester. At the same time, I can ask, she knows us, and I can ask her who she would recommend in your market for as a GU med-onc. Now, you can go over to Ann Arbor, but you may not need to, and I'll check with Dr. Heath and send her a note and ask her who she would refer you to with a BRCA mutation as a GU med-onc. I can't guarantee it's going to be at Henry Ford. It might be at Carmenos. But how's your insurance?
Pretty good. Very good.
Okay. Well, let me drop a line to Dr. Heath. I'm very happy to do it. See who she gets. If not, what I would probably do in your situation is I would include a GU medical oncologist outside of your area who's willing to work with Dr. Pallavi, or Dr. Pallavi is willing to work with some. It can be tricky because some of these medical oncologists don't like working with anybody else, but if they're not specialized in GU, they sometimes welcome it.
The Ford Health Systems is very good, but if I need to be speaking to someone with specialized knowledge, I was going to add that I'm not a doctor. I don't, I'm sort of at the mercy of whoever they set me up with.
Yeah.
And I'm just going on the basis of, her recommendation was to do the ADT for the recommended 2-year period, right? And other doctors I've listened to, I should say, have suggested that like an intermittent approach had about the same outcomes.
No,
and
I mean, we're not docs, but I don't think we'd agree with that. I think we'd say that you got to do it for at least 18 months for starters. And then you can start talking about ADT, but you need a continuous 18 months going on. But Len, you've got a bunch of people who want to talk. So.
Yep. Go ahead, Jeff Markey.
Yeah, James, I have BRCA2. I was diagnosed at 62, and I had surgery. I'm a 3+4, and I had surgery, and it took 3.5 years before it came back. And then I had radiation, and that gave me 2.5 more years. And then I went on ADT, and I've been on it for 7 years now. It's kept me alive. If I drop any of my drugs at all, my PSA, I was taking Zytiga, and instead of taking 4 pills, I took 3, and my PSA went from 0.2 to 1 in 18 days. The BRCA just doesn't allow, it prevents your DNA from correcting mistakes. So the mistakes happen and keep happening. I'm 14 years in. You may not like ADT, but if you have your PSA checked every 3 months now?
I do.
Yeah, I get mine checked. I've had mine checked every month for 5 years. And if you just get it, if it goes up, you need to get on ADT. And the thing is, if Lupron works for you, Lupron or Orgovix, if it works for you, if it keeps you undetectable below 0.1, then that's all you have to take. You're not castrate resistant. Once that stops working, then you got to get on abiraterone. And here's why you want to use abiraterone. I know it probably gave you hot flashes, and by the way, you want to be real active when you're on ADT. You want to do a lot of exercise.
Oh, I exercise every day.
That defeats the fatigue that it causes. But the reason you want to be on abiraterone is I was on it for 2.5 years. It does affect your heart, and it caused me to have AFib events. It raised my blood pressure. But after 2.5 years, I was able to move to darolutamide, which for the last 10 months have kept me undetectable. And the thing is, there's a sequence of how you do this, and it's best to move from abiraterone to one of the lutamides, darolutamide, apalutamide, enzalutamide. That works best for people. And if you've got BRCA and it keeps coming back, you want to have. All right, now as far as PARP inhibitors go, boy, Rick really did say what's important. My oncologist would not let me take a PARP inhibitor because she says it's just too hard on your body. And I will take it when darolutamide stops working because that's the last thing I can take. And I do know we had one guy on here who had BRCA2 who was 26 years in, and he had taken it for at least 3 or 4 years, and it worked for him. Now, it does affect your white blood cells and your platelets a lot. And I mean, all of these things can affect those, your red blood cells, your other CBC tests. But you know, if you keep healthy, you can overcome those things. There's a sequence of events you could follow from one drug to the next, which has given me 14 years and can allow you to live, even though you've got a Gleason of 8, can allow you to live longer as well. So, you know, just like Rick says, get yourself a genourinary oncologist. I've had one for about 7 years, and she really guides and knows what the correct sequencing of things to do are. So your PSA was undetectable last you checked, right?
Correct.
Yeah, well, that's good. That's good. It's hopefully your next one will be, but when it starts to rise, get on ADT. You were on Lupron? Was that it?
Yes, Lupron
Yeah.
and Eligard. I have a question though for you. As far as getting your PSA tested, given this gene mutation, do you recommend getting it tested every month?
Well, I see. Jim says yes, but it depends. I have it tested every month because it will come back for me in 1 month if I don't do it. You may be able to do it every 3 months. I mean, if your next test shows you're still, below 0.1, which is undetectable, then maybe you could do 3 months. But with BRCA, you never know. It could pop up any time, and you find out you're a 30 after 3 months, and you've got to do something quickly to get it down. So talk to your doctor about that. I cannot advise you about what the ideal thing is to do, but get a GU oncologist and talk to them about it, because your doctor is not going to be. The medical oncologists do not have the time to spend to know what's going on with the latest things in prostate cancer. As a result, they are not the best doctor to go to because they don't really know all the ins and outs. So that's why you want to, as Rick mentioned, he gave you the name of a GU oncologist, I think, and go to one and you get an opinion from them. It may be you want to get monthly tests. How long have you been off the ADT?
Um, Several months now.
All right. Well, if every 3 months may work. You never know. I think, I don't know, if you have any other questions, you can ask them now. Otherwise, I'll let somebody else talk.
Now, this has been very helpful. Thank you.
Sure.
Hey, Richard Fisk, you have a comment.
Observation. James, there are lots of ADT side effect mitigation strategies. I am on Lupron and Zytiga. They started me out on 1,000 milligrams Zytiga. I couldn't handle the side effects. They dropped to 750, couldn't handle that, dropped to 500, which I've been on now for almost 2 years. And PSA remains undetectable. Other people have mentioned various ways to deal with the side effects. And if you start looking, there are lots of things to do, primarily exercise, but there are other things also. But whatever you need to do to be able to stay on ADT, that seems to be, at least for me, the imperative is to stay on the ADT, and then that's what the studies seem to show is 18 months to 2 years, and then deal with the side effects. It sucks, but if you can get through it, it's worthwhile.
Yeah, I was not a fan of the side effects, so it was really kind of a cost-benefit decision. And but now with this gene mutation, it does change the equation. And
Yeah.
Yeah, of
Not
course.
only does it change the equation, but I mean, and this is totally anecdotal, but I can tell you that for men that I've known who are 4+4, they just got to stick it out. I mean, if you were 4+3, maybe, but with 4+4 men, you've really got to tough out that 18 months solid, and then, you know, if you can hang on longer. But there is research that solid research, which I think Dr. Pallavi may have been aware of, that you've just got to tough it out for that first initial period, and it's hard. We've all done it. Everybody in this room has been there, so we truly get it. And there are a lot of guys in this room who are doing who are doing intermittent now because they're living with the disease for the rest of their life. I did 28 months. I was T3A, and thank God, knock on wood, I got a durable remission, and it hasn't come back in 17 years. But that said, you know, I'm lucky, but I was willing to do the time at the beginning. Dr. Jeff, did you have something you wanted to say before?
No, but hearing this, I'm a Gleason 9, and I have been on combinations of Firmagon, Eligard, and now Lupron plus abiraterone for 13 months. I'm going to stick out the full 24. The side effects, I hate them, but I also like to be alive, and I know that my best odds are stick it out, tough it out, 11 more months, and I think that gives us the best chance to stick around rather than not to be on
Yeah,
these medications.
yeah. One thing I just took a quick look. It appears that there's one GU medical oncologist at Henry Ford. I think she's at Henry Ford. Her name is Clara Wang, HWANG. I think she might be in the Henry Ford health system. It's not clear, but I can tell you that as of May of 24, they were trying to hire a GU medical oncologist because I can see their hiring notice right here. So my guess is they probably don't have one right now, and we just encourage you to add one to your team. I mean, I have a couple in mind, but they're not local. Might mean that you've got to go to see them the first time, but you know we've got options for you. in different places. So Rochester, Minnesota, Houston, Chicago. Don't really have anybody that we work with closely in Cleveland. There are a couple there, but we don't. Pittsburgh, maybe. But there aren't a lot of them, James. That's the thing. And for us, we tend to refer to those that we know will really listen to you as a patient. Because some of them don't listen. Some of them don't listen either. And so.
All right, James, you got quite a lot to digest tonight.
Yes,
So
thank you.
keep coming back and let us know how you're progressing, what choices you've made, and we'll give you our 2 cents whether you want it or not.
Terrific. Thank you.
I'm looking for Stuart. Oh, yeah, there's Stuart. Okay. Stuart, you're also new.
Yes,
So
I am.
let's go on to you. So you heard the questions that I'm going to be asking. So how old are you, Stuart?
74, soon to be 75.
Okay. And where do you live, Stuart?
Bellingham, Washington State, about 90 miles north of Seattle.
Okay. How did you hear about? Oh, you were already a member, or you were a member of the intermediate group of AnCan, right?
I don't know that I ever officially reached that status. It was a one session situation.
Oh, okay.
I'd like to just interject here a second and say how Stuart came to the group because I love it as an AnCaner. Stuart's wife joined the Care Partners group, and she enjoyed the session, and she thought it would be great for Stuart to join, and so she pulled him in, and he was in the low intermediate for one session, and then we said probably should be here, and he's been in the Men Speaking Freely, which I think he enjoyed, and that's how we found Stuart.
Okay.
Well, I found you guys on the internet just trolling, trying to collect more information to be able to make more educated decisions. And then I stumbled across you guys and I thought, yeah, this is a place that's going to give me the best chance.
That's right. We're glad you're here. So, how old were you, Stuart, when you were first diagnosed?
74.
Or so less than a year.
Right.
And what was your Gleason score?
My Gleason score was 4 plus 5. It had
Okay.
95% 4 and 5% 5.
Okay. And what was your PSA level at the time of diagnosis?
I think I'd have to say 18.
All right. And were you seeing a, well, first tell me, what was your primary treatment? Radiation or surgery?
It was radiation. It was
Radiation, okay.
it was the 25 or 26 session ISMRT.
Okay. IMRT. And where was that done?
That was done at Fred Hutch.
Red Hutch. Okay. Good place. And do you have hopefully you have a medical oncologist on your team?
I do. I believe I'm frankly not 100% sure of her certifications in that, but that's how I think of her.
What's her name?
Hiba Khan, Kahn, Kahn.
Anybody know if she's a GU oncologist?
So
All right. So,
is this
Fred Hutch.
at Fred Hutch?
Right.
And there's a Heather Chang, Fred Hutch, who we know very well, who's very good. Is that who you're thinking of?
I've not heard that name. I'm only aware of the people I contact, and
Okay.
How do you spell Khan?
Kahn.
Okay. Somebody can look that up for us, please. And all right, so they did biopsy. They did some scans. I'm thinking, did they
Right.
identify if?
I started out in Bellingham with a TERP about a year before, and
Okay.
then things didn't get better, and we wound up having a cystoscopic exam, then on to an MRI and a CAT scan, and a MRI and a biopsy.
Okay. And was the cancer confined to the prostate or outside?
They've identified some nodes that are involved, and also the uh, seminal vesicles.
Okay. Pelvic lymph nodes?
I'm sorry?
Pelvic lymph nodes?
Yes. Regional,
And
local advanced high risk with the nodes, and which were regional, and
right,
the vesicles, seminal vesicles.
right. Okay. No bone metastases.
No bone or soft tissue mets.
All right. So you had the radiation, and how long ago was that?
I finished the last session on May 24th.
Okay. And you're on some form of hormone therapy, ADT at least,
Lupron.
just
And
Lupron?
well, she put me on abiraterone 1,000, and my liver was not happy, and it negatively impacted two of the enzymes. And we tried to get it to work at 3 pills or 2 pills, and then it was close on the enzymes were close at that point, so we decided to give 1 pill a trial run, and that didn't work sufficiently enough in her eyes to have me take it.
So did she switch you to another,
No,
to an
and
end?
this is one of the questions I have. So the question I have now is, given what you guys are talking about, the value of staying on Lupron or ADT, how does that intersect with the principle of doubling and tripling up with medications? What is that intersection like? On one hand, I read about the desirability of doubling up on medications, and I only wound up with one after the issues I had with abiraterone. So my question is, would it be prudent to get on something additional, given what appears to be an advantage to doubling up on medications? And I'm just
Yes,
repeating things I've heard now. I don't have any knowledge
I
of it.
think I think the general consensus is that you should be on a second line hormonal therapy, androgen receptor blocker, something like Xtandi or Erlita or darolutamide, which is Nubeca, any one of those, since you can't tolerate the abiraterone. And I'm surprised somebody just posted that your Dr. Khan is a GU medical oncologist, and I'm surprised
Oh,
that they haven't put you as a Gleason 9. I'm surprised they haven't added an androgen receptor blocker to your Lupron. So I would
well,
definitely talk to that doctor uh, about, why aren't you prescribing an androgen receptor blocker?
yeah, well, I have an appointment with her in about 3 or 4 weeks.
Okay.
A routine Lupron office visit situation.
So where's your PSA right now?
Right now, it's undetectable,
Good.
and it dropped rather markedly and quickly.
Very good. And did you have any genetic testing?
You know, I hear you guys talk about the BRCA, and I had that offered to me, and I took it, but I don't. I had it was negative for 2 and 3, or 1 and 2, whatever, for the 2 ones that they test,
Right.
and
Is
it
that all
had.
they tested for, or did they test for any mutations?
Well, there's a whole bunch of unintelligible numbers and letters beneath it, which I presume were negative also, or I'm not sure what it means. It says
Oh,
value negative.
so did the doctor told you that you have no mutations that are actionable?
That's essentially the conclusion I drew, but I don't think I heard her say those words.
Okay. Um, so diet and exercise, they educated you on that, or you educated yourself?
I educated myself about 50 years ago.
Okay, very good.
No, I've got that covered. I've got about an hour a day of aerobic, and I'm working up to about 30 to 45 minutes on resistance 3 times a week. And
Okay.
aerobic is
Yeah,
every day.
very good, very good. Um, let's see. Do you have any questions for us before I open it up to everybody?
Well, I happen to think that Dr. Khan is a very sweet person, and she's personable and trying to work on my behalf. But I just don't have the basis of knowledge to know if I'm working with the right person or not. And at this point, on an interpersonal level, I think she's great, and I don't have a bad word to say about her. But uh, I'm wondering if this move or non-move regarding a second agent is foreshadowing maybe she's not up to date, or
Well,
or maybe she has some recommendation on this next visit, and she didn't want to go bothering it in the middle of visits, given I was doing well on the PSA scale, so to speak.
yeah, before you throw her overboard, have a conversation with her, and maybe she has reasons why she did not want to prescribe a second hormonal drug.
Well, one thing that I do remember from the conversation is that she suggested that the insurance company wouldn't cover the medication unless you could show that your PSA was going down and you were becoming insensitive.
No,
No, it's not true.
that's not right anymore.
That's not
Problem
what.
is, you can't switch to another medical oncologist within the Fred Hutch system. That would allow you to do that. So you'd have to go outside of that system if you wanted to change medical oncologists
So I couldn't just go for a different person
within
and
the
just,
group. Not
yeah.
typically, no. I don't know if Fred Hutch is any different than most institutions, but they typically don't allow that.
Well, I guess we'll cross that bridge here when we come to it and
Yeah.
see how she
Uh,
handles.
Jeff Markey, you had your hand raised.
Well, I was just gonna. He seems to be castrate sensitive, so yeah, that's maybe
Yes,
why
he
his
is.
insurance company doesn't want to put him on abiraterone or something else. Well, one of the glutamides, because he's castrate sensitive, and they want to wait till he's castrate resistant
No,
before they
no,
put him on a
that's
second one.
that's that's not right. That's not right, Jeff.
Yeah,
If
but the insurance companies, Rick,
Jeff,
they're
Jeff, he's metastatic hormone sensitive. Okay,
yeah.
metastatic hormone sensitive would allow him to access enzalutamide, abiraterone. It wouldn't allow him to access darolutamide unless he did it with docetaxel. However, we know a bunch of people that have done it and that some of the doctors can get it. But the fact that there is no, as Len correctly said, he should be on a second line anti-androgen. That's standard of care. Why Dr. Khan hasn't put him on, we don't know. I mean, there are a number of good docs that we know. I mean, the issue with this lady is she's pretty young and inexperienced. She's she's got a relatively good, it looks like she's got a relatively good residency. She did a fellowship at University of Washington and a residency. So University of Washington's always had really good GU medoncs, so she's trained with some really good GU medoncs, but she's inexperienced. We would probably recommend Schweitzer or Heather Cheng, who we mentioned before, or there's a couple of other guys. I think is it Yastrovsky, something like that. But it is very hard to switch once you're with somebody. So I think you've got to sort of push her and say, why have you not added an androgen blocker if the abiraterone wasn't working, Stuart? And frankly, I wouldn't wait 4 weeks until your next Lupron shot. The other thing is, I'd see if she could switch you, and if they'll pay for it, I'd switch you from Lupron or Eligard to Orgovyx, because it's going to make a big difference when you come off of it. God willing, you'll be able to come off of it. And we see a much faster return of testosterone. So it's sort of a preferred drug. It's going to have much the same side effects. Bill Lee, you got your hand up. You're muted.
I missed the first part of the conversation, so I don't know if it was added, but is this the first Lupron that you've gotten, or you've been on it?
No, I've been on it. I've been on it since February 8th.
Okay, when I was put on Lupron, they held off for 3 months before they put me on Xtandi also. I just wanted to see how the Lupron worked first.
Yeah, but he was on abiraterone and didn't do well on it, Bill. So,
Dr. Jeff, you're up.
So just so I know I copied this down correctly, it's an androgen blocker that I'm looking for.
Yeah. So just to explain, there are what they call androgen receptor signaling inhibitors, and there are several there are 4 of them. 3 of them work very similarly, and 1 of them works differently. The one that works differently is abiraterone. The other 3 basically stop the androgen receptor from feeding on testosterone. They're like a key that goes in a lock, and when that key's in the lock, the testosterone cannot get in; it's blocked out. And those are enzalutamide, apalutamide, and darolutamide. Now, what we're saying is, if you didn't do well on the abiraterone, which is processed through the liver, then maybe one of these other 3, which are not processed through the liver, might work for you. But she was right in giving you the abiraterone first. That's the best protocol.
Right. Okay. So it's that other 3 in that class of drug, the enzalutamide, the
I'll put them in the chat window for you.
Thanks.
Okay. And you'll see.
Dr. Jeff, we'll try you again.
Yeah, Rick, for people who are going to come off of Lupron or Eligard and go on Orgovyx, what is the window of time? If someone's been on it for a year and a half, should they do the final 6 months, the final 3 months? What would be the best way to do that, to get off of the injectable and onto the Orgovyx?
Oh, I don't think we know, Dr. Jeff. I mean, I don't think that there's, I mean, not that I'm aware of any studies that have been done. The problem is that the LHRH agonists take a long time to reverse. The antagonists take less time, and the oral antagonist takes the least amount of time. My feeling is that once you've been on it for about 18 months, you're probably a bit behind the 8 ball, but it's still not going to hurt you getting off of it. But I honestly couldn't tell you. I mean, does anybody else have aware of any studies about switching your LHRH in the middle? Len,
My
do you know any?
oncologist,
No, I'm not, but I would say the sooner the better. Why, there's no reason why you need to wait any longer, Dr. Jeff. Just switch now.
my oncologist had me switch when I was due for another Lupron shot. The day I was due for another Lupron shot, it was 6 months. I started Orgovix.
Well, yeah,
Yeah,
that's good advice.
Yeah, but the question, I agree with that. But the question is, I think Jeff's question is, how long? How long were you on the Lupron before that, Jeff Marchi?
6 years.
6 years. So, if Jeff Marchi came off the ADT altogether, how quickly would he come back? Nowhere near as quickly as if he'd been on Orgovix for 6 years.
Stuart, any other questions for the group?
I'm just feeling a little bit overwhelmed of trying to shake this, have the conversation with her, because I already asked her, about the issue of replacing the abiraterone with something else, and she said, you're okay for now. And then, so calling her up again and saying, well, I've had some discussions, and I'm just wondering, do you still think it's the best thing is to stay with just the Lupron or switch to that androgen blocker? And would you keep the Lupron with the androgen blocker or replace it? Keep it with it. Okay.
Keep it, yeah. You're going to have to be your own best advocate, which is our motto here, Stuart. It's your life. Don't be intimidated, thinking that, oh, I don't know if the doctor's going to like me challenging her. We're not giving you our opinion. We're telling you what the standard of care is.
Mm-hmm.
Okay, so by the NCCN standards, National Comprehensive Cancer Network, they're the ones that draw up the standard of care protocols for patients of different cancers, including prostate cancer. And so for someone like you, the protocol is to be on an ADT drug such as Lupron and an androgen receptor blocker or abiraterone, but abiraterone didn't work for you. So, don't feel like
Okay.
you're out of line by having this discussion. I mean, I might disagree with Rick that being that your PSA is undetectable, I don't see the need to call her up and, rush this conversation. If you're going to see her in a couple of weeks, I think that probably safe, probably okay. If that makes you feel better about having the discussion with her.
All right.
One
Tell her you
thing
want to
you
go on
can
enzalutamide.
one thing you can say to her is, you'd like to get another opinion from one of the other GU medoncs, and can you have a meeting with her and Dr. Cheng or her and Dr. Schweitzer, and see whether what they would do, sort of ease her into it that way,
Right.
because if you say that, she may finish up calling one of them and asking them. Evan Yu is interesting because if you remember, guys, we had a guy here, and Evan Yu didn't want to put him on a second-line anti-androgen. This was probably last year, and she may have trained with Evan Yu, and Evan Yu's reluctant to add the second-line anti-androgen. So I don't know, Dr. Jeff.
Stuart, Are you on a patient portal where you can communicate with your provider through a portal?
Yes, I can.
Okay, so send a note to her in the portal and tell her that you have a question about your medications and put it in that on the portal. They have to answer you on the portal, and then when you see her, so you're not springing it on her, give her a heads up. I do that with my provider. I send them questions over the portal and they answer me very promptly. And I tell them, hey, in my next visit, I want to discuss this and that. They're prepared. They appreciate that. And, you're not on the spot.
Okay, that sounds like a good idea. Thank you. I appreciate all the feedback. A little intimidating, but I get the point. I'm not generally a wilting flower in my life otherwise, but when the stakes are this high, it's a little intimidating. But thank you all again.
Okay. Let's see. I have Marc Valens next.
I think probably I'll wait till next week. I've switched back to darolutamide from Xtandi, but it's only been 3 days, so I don't really have much to report. The first 2 days were great, and then today I'm going really slow. But let's give it another week and see where I'm at.
Yeah. Okay. Yeah. Next week, let us know. All right then. Bob Snyder, you're up.
I think he left.
Oh, okay. Then how about Tony Fig? You're up next, Tony.
Yeah, I saw my medical oncologist today, and my PSA is still negligible, and the testosterone has come up a little bit, 623. So it looks like I've got a pretty good durable remission going on here. So I was pretty happy about that. I asked him a question about the Foundation One test results and if there's anything that I should or could be concerned about, or uh, how you look at those results for any future uh, return of cancer. And he said that, yeah, really the only type of mutations that you'd need to worry about would be the ones that have an amplification, which are a number a little higher than what they normally would count in their whole process. So he said that those mutations just are there and inactive at this point. So I don't know if anyone else has given any thought to what you do when your prostate's removed and the tumor's gone and you have the information from the tumor testing.
Well, when was the last time you did the FMI test?
A year ago, no, 2 years ago in October.
Okay, and at that time, yeah, I see it here. You had CHEK2, right?
That was for the color. And then on the Foundation One, I think there was like 5 mutations.
Okay, I'm not sure that I ever saw that. Can you tell us what the mutations are?
I don't have that in front of me right now, but I can send you a copy of that.
Okay, I mean, I think it really depends on what those mutations are. I mean, the germline CHEK2 is an HRR homologous recombination repair mutation. That said, it's not very actionable. We don't know anything that we can give you that will respond better because you have that CHEK2 mutation. the FDA has approved PARP inhibitors, but it's an erroneous approval in our view and in the view of most good GU medical oncologists today. It was just the way that the trial was constructed that it got included with a bunch of other things, most of which were not actionable other than the BRCA1 and the BRCA2, maybe the ATM, maybe the PAL2, but that was about it. But that CHEK2 is going to definitely show up on Foundation Medicine, but whatever else showed up, I think we just need to look and see. But at this point, since you're undetectable, you don't really need to sort of worry too much, because you're not at a point in time where you would want to do something different. I mean, if anything, how long have you been on continuous ADT, and are you just on ADT right now? And
No, I was on from October of 22 to April of 23.
okay, and then
I
and
did radiation.
right, and right now, are you on anything or not?
No.
Okay, so you're at a point where you just got to keep watching it, wait for your testosterone to come back. It'll hopefully happen at some point. You'll feel better, and then worry about what you're going to do next if it comes back, right, Len?
Yeah, I totally agree. You're in a good spot right now, Tony. There's no reason to worry about any mutations. But certainly, send us a copy of that report so we could take a look at it. But,
Okay.
there are very few mutations for prostate cancer that are actionable. Most of the mutations, they really don't, many of them, they don't even know the significance of the mutation, whether it's just what they call a passenger mutation or a driver mutation. Driver mutation meaning that's what's driving your cancer. And even of the ones that we know are driver mutations, there isn't always a drug that is available to treat it. Like Rick said, BRCA1 and 2 is the main one. There might be a few others that they've had some success with, but not a lot. So anyway, the bottom line is don't worry about it.
Yeah.
Yeah,
Dr. Jack had brought up the topic of sarcopenia, which is the diminishing of muscle mass, and Prostate Cancer Foundation had a webinar on the other night with a cardiologist and an oncologist, and I brought up that question that does it affect your heart muscle as well? And when you're on ADT drugs, and they said it's not as pronounced, but it does have an effect. So that would bolster Jimmy Greenfield's enthusiasm for exercising and for strength training.
Absolutely.
For a bit of humor, last week everybody was talking about driving Porsches, and I heard that men that drive Porsches do that because they can't get women any other way.
Oh,
oh, shots fired.
oh, I won't pick out names, but there's a couple of silent people in this group right now.
Yeah.
Excuse me, I got to testify.
I beg your pardon.
There's something that works very well also is one of these guys.
Yeah.
Very effective. Every bit as much as the Porsche. If you have the Porsche and the ES335, then you're really cooking.
Yeah.
Okay, guys, I got news for you. A Volkswagen Carmen Ghia was designed by Porsche. It's the
Yep.
closest thing I got to driving a Porsche.
I
Yes,
remember the
true.
Carmen Ghia. Yeah.
Oh yes. Oh yes. Oh yes. Oh yes.
All right. Joe Commander, you are up.
Okay. I don't know how much this is fair, so you guys stop me when I am not being fair anymore. But I have a meeting on Wednesday, 2 days from now, with my medical oncologist, and we're going to discuss going on hormone therapy, which I have never been on. And she has recommended already, not officially, I guess, but that I do this, and that she would put me on an ADT drug first, and I can choose between Lupron or Orgovyx, and then we would see about a second drug. So some of my questions have to do with whether I should be doing one or two. And so I don't know, what I was hoping I could do is just tell you the questions I have, and then see if you have recommendations for other questions or whatever. Is that okay?
Well, first, Joe, I don't
Sure.
know about the others, but I could use a refresher on your prostate cancer history, like what your Gleason score is, how far along are you?
Okay. I think it's 4-3, but it might be 3-4. I just get mixed up. I think it's 4-3.
Okay.
In 2013, I had my prostate removed. 3 years later, the PSA came back again, and I needed to. I had radiation, and I think it was 32 days of that to the prostate bed or whatever, and then for a few years I was okay again, and then they started finding one at a time spots in what are those things, the lymph nodes, right? So I had one spot, and we did SBRT radiation, and we did that twice over the course of 3 or 4 years, and now it's not really knocking it down anymore. So, and the last time there were two spots, that was in January, and one of them was pretty close to one of the spots they'd hit before, and they thought it was probably dangerous to do that, to hit that area again. And besides that, they kind of think the game is up, that we have to move on to something else. So that's kind of where we're at.
Do you know what your PSA doubling time is, Joe?
Sort of. I'd say it went from 2.1 in May to 4.3 a week ago. So
All right,
it's on
so
the rise.
May to now, was it about 5 months?
Yeah.
Okay, so yep, systemic therapy, hormone therapy sounds appropriate.
Yeah.
As you probably gathered from the conversation we just had, you're better off with Orgovyx than with Lupron because it drives down your testosterone faster, and when you stop it, if you take a drug holiday, it'll come back faster. So if your insurance will pay for that, I think Rick would probably agree that Orgovyx is the better drug to choose. As to whether or not you need a second line antiandrogen, like we were talking about before, the receptor blockers, I'm not sure. In your condition, I mean, you're only a 3-4 or 4-3, and Well, maybe with the 5 month doubling time, that might call for a second line anti-androgen. I don't know. What do you think, Rick? You're muted.
Where are the spots, Joe, that they're nervous to radiate again?
They're kind of in the, I would say, hip or pelvic area.
Okay, but they're in the bone.
No, I mean
Then
I haven't had a PSMA since January, so maybe they are now, but they weren't.
but so they were nodal. They were nodes, and they were in the nodes and
Yes,
not in the bone, right?
right.
You know, I think we've just learned that doublet is better than singlet.
Yeah,
But I like the approach of putting you on the Orgovix and then adding something to that. But I think if you want to get the biggest bang for your buck, it's probably the way to go. And, hopefully we can get you on for several months, a year or so, and then get you off. That's
yeah,
the idea.
yeah. Well, that was my inclination from listening to you guys for a while, and so I was going to ask her questions about her reasoning about that and whether that might not be a possibility. Yeah, one of the other questions was just what tests should I take beforehand, and I'm thinking of a DEXA scan, uh, testosterone test, and I don't know, should I see a heart doctor, for example?
Do you have any history of heart disease?
Not really, no. I mean, I have high cholesterol, and I'm on medication for that.
How high?
Well, now it's pretty good. I don't remember exactly, but it went up into the high 200s, I believe.
Ooh.
Well,
So,
baseline testosterone level and baseline uh, bone density is a good idea.
okay.
Yeah, I would do that.
Anything else?
I don't know that you need a cardio baseline.
Okay.
Anybody else have any?
Jim Marshall has his hand up.
Oh, go
Uh,
ahead, Jim.
Opinion of mine, you should get them all done. Establish a baseline because they can vary. Uh, you need to know specifically potassium, sodium, uh, probably, and my blood counts everything else because I know with me, I started the ADT plus the Zytiga, and I've had low HGB and hematocrit about a 10% low ever since. So it
So
would
you
be
were
nice
on
to
you were
understand
on
all.
ADT for 5 years, right, Jim?
Well, it started early, yes, and it continued on, and it's even low now. Well, it's still at about the same 10% low.
Well, he's gonna get routine CBCs and metabolic panels. They'll cover all the chemistries, the hemoglobin, hematocrit, all that stuff.
Oh yeah,
That's just
but as I say,
what's that?
establish a baseline first before it starts, because otherwise you won't know.
Well, when's the last time you had a
My
blood test, Joe?
Me?
Yeah,
Other than PSA, I don't think I've had anything.
you never
Well,
had
you
a
know what?
CBC.
That's not true. Uh, when I went to see my primary care doctor, he had me, I test for cholesterol and a few other things. I don't even know what they are, but that's probably what you're talking about.
Not really. CBC, like hemoglobin, hematocrit, white blood cell, red blood cell. You don't remember
I don't remember that. I'd have to look.
if they were,
But that's what you're talking
if
about.
you, if they didn't, yeah, if they didn't do that, maybe you need another primary care doc because they certainly should be doing
Okay.
basic screening like that.
Right.
And another chemistry profile they call the metabolic panel, which
Okay.
Dr. Jeff knows a lot more about that than any of us. He's the director of the lab. What do you think, Jeff?
So just make sure, I mean, if you're going to go on abiraterone, let them do your liver function tests before you go on it. It tends to initially raise your liver enzymes, and you follow that closely. I know with me, some of my enzymes went up and then came back down to normal subsequently. But if you don't get a baseline, you don't know where you started.
Right. So what I've heard you say is add a metabolic panel and a liver function test. Is that right?
They're on the metabolic panel.
Oh, they are? Okay.
Yeah.
The ALT and AST, aren't those two good ones too?
Yep. Yes, they're on it.
Hey, how's your blood pressure?
Pretty good. I don't even take, I still run, so I have a pretty,
abiraterone will raise your blood pressure.
yeah.
And the question is how much it will raise it.
Yeah, I'm not taking any medication for it at this point. But
Yeah, I wasn't either, but now because of abiraterone, I have to take 3 pills twice a day for blood pressure. And my blood pressure is great. It's 100 something. It's not even 110. But because I'm off abiraterone now. But just something to be concerned with. Check your blood pressure if you can regularly after you start it to make sure it doesn't rise too much.
Just want to say that, Joe, the more you run, the less likely you'll need it. You know that.
I hope that.
Oh yeah, no question.
And if you get hot flashes, come back and we can give you a lot of advice.
Okay.
Rick, are you recommending Chang and Schweitzer for Joe? Is he in Seattle area?
No,
no. That was in there from when we were talking to Stuart.
Oh, okay.
I'm from Philadelphia. I go to Fox Chase.
Oh, you're at Fox Chase, Joe?
Yes.
Yeah, who do you see there?
Dr. Gatalia.
Okay.
He's a GU medical oncologist.
Okay. Anything else, Joe?
No, I think you've been helpful. Thank you.
Let's see. Go ahead, Jeff. Dr. Jeff.
Joe, let me throw one other thing at you. If you go on abiraterone, you're going to go on prednisone too. And the combination of these testosterone blockers and prednisone does put us at higher risk of osteopenia, osteoporosis. And so I would have a discussion as to whether you should go on a bone protector if you're on prednisone and, let's say, Lupron and abiraterone. And certainly, if your DEXA scan shows any degree of osteopenia or a porosis, then you should have that conversation about going on something like Prolia, an injectable medication that protects your bones from fractures.
To tell you the truth, I'm hoping I can get on darolutamide. I don't know how likely that is, but that doesn't require the
no prednisone,
right? Yeah.
The thing is, you have a better chance of starting off with abiraterone and moving to darolutamide when it stops working. It will give you a longer chance of staying alive with a low PSA because the recommended sequence is abiraterone first, darolutamide second. And recent studies have shown that people get off darolutamide less than they get off either of the other lutamides. So it is a good choice, but abiraterone to darolutamide gives you more time if you need it.
I don't know that they would approve darolutamide for you, Joe. It's certainly not an FDA-approved indication in your case. But having said that, some guys do manage to get it, even though it's technically it's not FDA an FDA-approved indication for your particular case. But you know,
And what about my particular case?
well, I mean, darolutamide has been approved for metastatic non-metastatic castrate resistant, which you're not
Yeah.
castrate resistant. You've never been on hormones,
Right.
or it's approved for as part of triplet therapy for high volume metastatic hormone sensitive prostate cancer, which you don't have that either. Triplet therapy meaning it has to be taken with chemotherapy. Yeah.
Yeah. Now, there are docs who can get it, like Dr. E and Dr. Schultz. I don't know how they do it, but they're like wizards, and they get it for you. And so there's, some wheeling and dealing here. I mean, I don't know whether your doc may say to you, "Oh, I can't do it. I can't do it," but it can be done. But I'm not really sure how they do it.
Well, I can tell you how I did it.
Oh,
Joe.
now look, hold on. Norm Pollock. Norm, you must have heard us mentioning you. Are you there?
Well, yeah, I'm trying to be there. Let's see if I can get the camera going here.
You're trying to
There
be
we
there.
go.
So this gentleman,
here.
Joe Commander is saying, does he think he can get darolutamide? And we just said, well, not officially, because he's metastatic hormone sensitive and he hasn't done docetaxel. But there again, Dr. E got it for you, right?
They depend on which doctor you go to, evidently.
Yeah.
She got it for me probably 2 years ago in end of November.
Yeah.
When 22 months ago, she got it for me, and paid for it too. So.
It is a toughie. I mean, some of these docs can do it, some of them cannot, and we know what the official status is, which is that you're supposed to be taking it with docetaxel, but that's from 2022.
Yeah, right. Well, the urologist told me, no way, I can't get it. I won't even try. I can't get it. So I have a hard enough time getting Orgovyx, let alone darolutamide.
I tried to get it through Dr. Borno at UCSF, and she totally discouraged me. So I went to my med onc. She's not even a GU med onc in Little Medford, Oregon, and she got it. And I'm, metastatic, castrate resistant. She got it for me in 3 days.
Well, the castrate resistant, that's what it was for originally.
Yeah, that's an FDA approved indication.
Oh, no. Non-metastatic.
Oh, that's right. Yes, you're right.
I'm metastatic.
Oh, I thought he said it was...
And Mark's metastatic, but this whole non-metastatic dance, which was created by Bayer, is really a bunch of hooey anyway. But I don't know, Jeff Wood. Are you in this? Are you in this ball game too?
No, but I what Jeff was saying. Is it still preferable to start with that just to have the time on that before you go to darolutamide? Is that
right?
Still Is that still
Yeah,
the wisdom?
yeah. I mean, look. I think in a case like Joe, where everything's been real slow, I think the advice of his doctor is pretty solid. Start off, see how you do, and then we'll add something to it. So, in a sense, we could say, well, let's not get ahead of ourselves. We'll work with you when you get there, but don't set your heart too fondly on the darolutamide unless you want to go pay a visit to Dr. E or one of the docs we know can get it. I think Dr. Shmulewitz is another good guy at getting that darolutamide, right? Mr. Marslin? I caught him with his mouth full. Sorry.
See, but in the case of David and myself, we were able to get it after we complained that we had too much fatigue from Abby, right, David? Wasn't that your case? Yeah.
Could I follow up with Jeff Markey a moment? Is that how you say your name?
Yeah, that's real. What's up?
You had said that it's not a good idea to go on it first. Is that because at a certain point the first drug will become ineffective and you need to go on a second one, and it's good to have that one in your back pocket? Is that the idea?
Yeah, and there's an article, I could post the link to it.
Okay.
On, it was in the, oh, wait a minute, that's why I can't find it in the wrong place.
The studies have shown, Joe, that
in Lancet article, they specifically went into it.
The studies have shown that you do better if you can tolerate it. You do better going on abiraterone and following it with one of the androgen receptor blockers than the other way around. You're more likely to have success from the second line drug if the first line drug is the abiraterone.
Oh, shit.
Okay, does anyone else have anything they want to bring up? Because we've got 17 minutes to go, and I don't think anybody's on my waiting list.
Joe, I just posted the link in the Lancet to the Lancet article if you want to go check it out.
Oh, okay, thank you.
Bill Lee needs some time, Len.
Who? Bill Lee.
Bill
Okay.
Lee needs
All right,
some time.
Bill Lee and then Stewart. Go ahead, Bill.
Okay, mine's real quick, just an update. My PSA is now less than 0.008, so non-existent. Testosterone's at 29. The only thing I'm being bothered with now is bladder stones.
Oy.
They don't hurt as bad as kidney stones, which I've had too, but the bladder stones are irritating as all get out.
Yeah. Who are you going to see? Who's going to take over your care?
She's got one of her a new gal that's in that she's trained.
Okay.
She's trained on. I forget her name.
Okay. Well, do tell us, and tell us if you like her. There was a guy before you came on, but he sort of came on. He told us his stuff, and then he left. Who's at Henry Ford, but he doesn't have a GU Medonc, and he probably needs one because he's BRCA germline, and he's just starting out, and he's had radiation. And now that we don't have Dr. Heath in your greater Detroit market, either we got to send him over to Ann Arbor or somewhere else. But if you like this lady and you think she's good, please let us know.
Okay, I don't see her again until January.
Okay.
Maybe December or January.
But if she's been trained by Dr. Heath, it speaks well for her right there.
Yep.
So she was so not. I mean, I was with Jim Schrate, who's one of our moderators in active surveillance and low intermediate, and Jim knows her from the Zero board. And so she was in the corridor, and Jim stopped her, and they were, she knew him well, and he introduced me, and she was so nice to us. She knew who we were, and she was just really, really sweet. And then she followed up and sent me a note, and I'm hoping we'll get her to do a webinar next year. I mean, she's sort of a Dr. E type of doc. She's great. Well, I don't have to tell you she's great,
Yep, definitely good.
Yeah.
Yeah. Just trying to find my calendar here, but
I have a question before we go to Stuart. I have a question for David Opp. How are you doing in terms of your care, and have you had any luck or any thought? We've, like I say, we've got an outstanding option for you now, because Dr. Heath, as you just heard, is leaving, and she's going over as the chief oncologist at Mayo, not just GU, the chief oncologist overall. But I mean, if it were me choosing between Dr. Sartor or Dr. Heath, and both of them like us and we like them, but I probably would go to Dr. Heath because she's just so down to earth, and I mean, she's super smart, and she's lovely.
My current treatment, my PSA has been undetectable for the past 16 months.
Right.
I get scans every 3 months. The bone mets that were found in February of 2023 have basically disappeared on it. I'm currently on Eligard and 500 milligrams of Zytiga. And I hate to say, I might disturb you a little bit, but I'm happy with Dr. Kwon.
Okay. Well, all I will say is you heard it here first. So
I know. And his treatment plan is working.
Okay.
So, I mean, when it quits working, I guess it's time for, see what he's got or see what someone else has in mind as a second opinion.
Yep. Well, we hope you're on ADT, correct? And
Yes.
And how long have you been on the ADT?
18 months.
So, sometime in the next 6 months or so, you can have a discussion about taking a break and see how he responds to that. You've got Dr. Heath and Dr. Sartor in your hip pocket now.
Yeah. The last time we had a discussion was February of this year when we reduced the abiraterone. He felt I should stay on that combination for 2 more years. So it would be a total of 3 years.
Look, if you're tolerating it, fine. But, we tend to think here, we tend to feel, and we don't give medical advice, but we've seen people stay on these drugs too long, and then we don't have anything left. So, the more aggressive you are and getting a break and taking a break and then coming back to it, it seems to help in the long run.
Yeah.
But, that's a discussion that might be tough for you to have, but I think somebody like Keith or Sartor would be receptive to it. But what can I say?
Well, Kwon, the previous time I was on ADT alone, I had done 21 months of 36, and I stopped because of side effects.
Yeah.
And he was receptive to it.
Yeah.
But my cancer basically came roaring back after the vacation.
Yeah.
So
Well,
it might be a good idea.
we got your back. When it comes back, we've got your back, and I understand why you don't want to switch until you've got another decision point. But I just want you to know you've got if you're willing to travel to Rochester from South Dakota, you've got great options now. Really good options.
And I'll keep stopping in here. I mean,
Please.
the information is good.
All right, Stuart.
Yeah, I think I have a quick one. I'm into this about 7 months now, and my testosterone level when I first came in on the front end was about 500, and then over the next 2 or 3 months, it dropped from that to basically less than 10. So my question is that a good thing, a bad thing, or it's not a thing at all? It's just whatever you get, and it has no clinical impact.
Well, the whole point of you being on the hormonal drugs is to keep your testosterone level low so that it's not driving your prostate cancer. So it's good. It's good while you're on the ADT drugs, but if you go on a drug holiday and it doesn't rise, then you're just not going to feel good. You're not going to have an opportunity to rebuild your strength, endurance, bone strength, muscle strength, that sort of thing. I forgot already. Where are you in the treatment process now? How long have you been on ADT?
I finished the radiation. I've been on Lupron since the beginning, about 6 months, 5-6 months.
And how long do they recommend you stay on it?
2 years.
Hey, if he's a 10, he needs a second drug.
Oh, you're a 10? Gleason 10?
Below 10.
No, he's a 4+5.
Right, but PSA has not dropped below 10, he said. So he should be on
it's testosterone.
His
Testosterone has not dropped below 10.
Okay, I'm sorry.
So I guess in summary, I don't have anything to worry about that in itself, a low or absent testosterone.
That's what you want.
Right.
Yeah, it's what you want.
No, I get it. But further down the course of treatment, you're going to want to bring it back when you're supposedly on a holiday or checking to see if the cancer has returned or not.
Yes, but you don't have to worry about that right now.
Right. You've got enough to worry about.
You definitely have enough to worry about. Yeah.
It can be a little confusing because it's what you don't want, but it's exactly what you want. You know what I mean?
Yeah. Just at a different time.
Right now, you don't want any of that stuff.
Okay, thanks. All right, thank you, guys.
Gary's got his hand up, Len.
Well, go ahead, Gary.
Is there a silver lining to the fact that the testosterone does not recover as quickly after Lupron as Orgovyx? Does that help you in some way to avoid a recurrence for a longer time, that your testosterone is still very low?
Well, I would say the body doesn't really care what's causing your testosterone to be very low, whether it's an ADT drug or a failure to recover after you stop ADT. It's still low, and it's not likely to drive your prostate cancer. That's the silver lining. I don't know. What do you guys think?
Seems like maybe the silver lining to the Orgovyx may be that because it recovers so quickly, you'll find out sooner. If you've got a recurrence, because it's going to come back so much faster that you could get evidence of your disease a lot sooner. I'm just guessing.
Well, I don't know that that's a plus.
Well, no, but if it isn't, then you have a good longer holiday.
Yep.
Dennis.
Yeah, just my experience is my testosterone never came back because I'm on Eligard and Lupron up to close to 8 years now, on and off, intermittent. But during my intermittent time, and I get maybe 8 to 10 months somewhere in there on my break before the PSA starts to rise. But even then, my testosterone is still very low. I mean, down just probably above about 15 or 18 or so. Now I don't, unfortunately, I don't know what it was before I started before my diagnosis, before I started my treatments. It was low then or not, but I know if I don't do the exercise, if I don't get up and move and exercise, and walk every day and do weights, the fatigue sets in. But I've been battling it, with a low testosterone the whole time here.
I gotta tell you, my testosterone is I don't even want to say it is the envy of most of you guys on here. I'm in a good long remission. My testosterone's well over 700. But if I don't exercise, I'm 68 now, and life is just no good if I don't exercise. I know I'm conditioned for it. I'm accustomed to it, but it made the difference when I was on ADT. It makes a difference when I'm not on it. Yeah, it's a little better, but the contrast is much less than it would be if I didn't. I'm convinced.
Jim Marshall.
Okay, a war story. Let's see, ADT plus Zytiga, 5 years on a holiday. It took me to start recovering testosterone about 14 months. It did not budge. Then it gradually started to go up. It's been 25 months, testosterone up to 409, and the PSA at 0.06. So I don't know if it was because it took so long to start up that I have been extended this far, but I'm not complaining.
I got to tell you something, Jim. For your testosterone to start to come back in 14 months after 5 years is pretty amazing in and of itself. That's fantastic.
Okay.
Number one. Number two, God bless you at 80 years old to have a testosterone level of 409. I think there's a lot of people that would give their right testicle for that, to be honest. And
yeah, you said it didn't bulge. You said it didn't bulge when you meant to say budge. Maybe it's bulging now.
Budge.
It's bulging. Yeah. Maybe it's bulging now.
So I think you're doing phenomenal, and we love you, and we love the example you set. So I'm just saying, Captain. Just saying. Oh, and which allows me also to add that the Veterans Group will be meeting tomorrow night. We've changed the dates on the Veterans Group, so any vets, please come in tomorrow night, not in this room, in the Schmear room, in the other room, because Captain Jim will be leading that group tomorrow and on the first and third Tuesdays of every month. And it is a fantastic group. If you are having any issues with the VA, with TRICARE, with your benefits, or anything else. So for those of us struggling with brain fog, we can all take a lesson from listening to Captain Jim when he starts reciting the statutes in that veterans group.
I thank you very much.
All right, gentlemen, it is now the bewitching hour. Thank you so much for all your participation. Good session. We'll see you next week, Tuesday. Tuesday.
David Muslin, hold on a sec.
Oh, David, go ahead.
No. I want to talk to David afterwards, and I'm turning the recording off right now.